Chelsea. I'm the dietitian here at West Coast General Hospital. Today I will be presenting on my role and we'll go over kind of what some other dietetic roles can look like as well. I ended up here in Port Alberni. I took a job after university. I decided to move out to the West Coast. It's beautiful and I have no regrets. To become a dietitian, it's 5 years of school. You do 4 in the classroom and then a year of practicum. I did my schooling in Saskatchewan, where I'm from, my stomping grounds, and brought me out here. So today we'll go over, like I said, different types of dietetic jobs, kind of what nutrition assessments look like, some of what they encompass. We'll go over some patient examples, like people that I would typically see in my role. I also cover, in addition to the hospital, I provide coverage for West Haven, our long-term care center, so I'll go over what that looks like, some of the behind-the-scenes work that I do, and then we'll have time for questions. So there's a lot of different jobs you can get with a nutrition degree as a dietitian. You could be like a community dietitian where you work with like public health programs, schools, community organizations to promote nutrition education, prevent disease, that type of thing, more big picture work. You could be a food service manager, so managing nutrition programs in like schools, hospitals, long-term care centers. This is not my role. Sometimes people come to me with like kitchen type related concerns, although I would be qualified to apply for a food service manager position. I don't work in that role, so I actually don't have any authority over what goes on in the kitchen. You could be a public health dietitian, so working on like policy, nutrition programs, education at like, it could be a national level or a local level, developing resources. So the most common resource, like Canada's Food Guide, would be, that's made by public health dietitians. You could be a geriatric dietitian, pediatric dietitian, renal, oncology, sports research. Like there's a lot of different niche areas. In Port Alberni, it's a more rural community, so we have myself, our clinical dietitian, and then we have Daniela, who works in community, home and community, and Kaylee, who works in public health. And she covers Port Alberni and the surrounding area. And then, so like I said, I'm a clinical dietitian. I don't know if you can see that. Where'd my mouse go? I have no idea. Sorry guys, there's a box in the corner.
Okay.
So my role here is to like conduct nutrition assessments here, make a nutrition diagnosis, implement some interventions, and then hope to ameliorate any nutrition risks. So nutrition plays a really big role in recovery, chronic disease management, and just overall outcomes. So I will like conduct my nutrition assessments, so looking at like biochemical data, so labs, medical tests, procedures, anthropometric measurements, people's weight, and then nutrition focused physical findings, which I'll go over in a moment, and then the patient history. And then, any interventions that I make are going to be targeted at solving said nutrition problem and alleviating any of those signs and symptoms that they're dealing with. And then we monitor and evaluate just to determine if our intervention was appropriate, if change is actually happening, and we're working towards our goals. All right, so the Canadian Malnutrition Task Force developed this resource here, this subjective global assessment form. They are the same group that made like the screening questions for malnutrition. So when people come in and nursing asks that question, have you lost weight in the last 6 months? Have you been eating less in the last 2 weeks? Same group developed this. So approximately 1 in 4 hospitalized adult patients is malnourished or at risk of malnutrition. So this is like one of the big pieces of my role here as a dietitian. Malnutrition leads to increased costs for hospitals, for taxpayers. It negatively impacts a patient's physical health, functional independence, recovery from illness, injury, surgeries, and studies show that malnutrition is linked to a higher risk of mortality. And then something that I'm sure Isabel and Chanchal would be like right on board with, implementing nutrition interventions and therapy can help reduce length of hospital stay. I know we're all about getting our patients home. So this is something that I look at, is assigning like an SGA, subjective global assessment, value. So this looks at, like, it takes into consideration as part of my assessment, like intake, weight, symptoms that can affect oral intake. So if someone has diarrhea, constipation, heartburn, swallowing issues, nausea, vomiting, early satiety, all those things. We look at functional capacity. So if someone is bound to a wheelchair, bedridden, or if they're up and able to mobilize. Metabolic requirement. So if people have like lots of wounds on their body, certain types of cancers demand more calories, things like that can increase the body's metabolic requirements. And then our physical exam, which includes, so we can do like physical assessments kind of from head to toe, and looking at, under the eyes, you can look for people's fat pads under the eyes and around the temples, so you can assess for muscle loss. Around the ribs, you can look for musculature and signs of loss. The clavicle, again, that one's kind of tricky with some people have naturally very protruding clavicles, but shoulders, looking for if they're rounded, if they're more square, if the bones are prominent. You can look at people's quads. Their interosseous muscle between the thumb and forefinger is a sign of muscle loss if there's depression in it. I can show you that later, Haley. And then looking for fluid retention. So if someone has ascites, like the big kind of pregnant looking belly, or edema, that is another indicator that that is sometimes a factor of malnutrition. So, looking at all of that and trying to kind of quantify all that, and then you assign either an A, someone is well nourished, a B, they're moderately or mildly malnourished, or C, they are severely malnourished. These people are typically obvious. Like when you see someone who is like skin and bones and wasting away, we know, okay, like they're probably starving. But not always super obvious in people with larger bodies who may have had a lot of weight loss, who haven't been eating, and we see someone who lives in a larger body and assume, oh well, they have a lot of stores, they're fine, when in reality they can be quite severely malnourished. The other thing that we consider that I think is well known here, we look for cachexia or sarcopenia. So cachexia, we often assign that term when people are quite thin and frail looking. But cachexia is specifically the term that's used when there's an increase in the body's inflammation, its metabolic requirements, you see an increase in like cytokines, and that is associated with an underlying illness, most commonly I would say with cancer. We can't fix that with nutrition because nutrition isn't like the underlying cause of what's causing that malnutrition. So, you could, if someone is truly cachectic, you could like give them all the calories and the protein in the world and it's not going to touch them. With sarcopenia, so muscle and fat loss, it's muscle and fat loss that's like age related. So As you get older, you lose your strength as a part of the natural aging process. That is something that nutrition interventions are more appropriate for. So just a difference to consider. Sometimes nutrition can have a really strong role, and other times we're just limited in what we can do and what we can treat. Okay, so based off of the assessment, which would include the SGA, that score, and then looking at labs and history, all the fun stuff, we would make a nutrition diagnosis. So on our slide here, you can see this big list of possible nutrition diagnoses that people can have. So oftentimes they're not getting enough protein. That's a really common one. There's vitamin, mineral deficiencies. We don't often see those in Canada, just in a first world country. They're more common in other places. We're quite fortunate here. There are functional diagnoses, so chewing difficulties or altered GI function for someone that maybe has an ileus, post-op ileus. Physical diagnoses more focused around someone, maybe they don't have anything wrong inside their body, but they physically can't get the food from the plate into their mouth. That's where the issue is. That's the etiology of their nutrition concern. Food safety and access, so maybe their low socioeconomic status, they don't have access in community, that's where their nutrition concern is coming from. So we will assign a diagnosis, and then our goal is we want to, if we can fix that diagnosis, fantastic, or if we can just ameliorate the signs and symptoms around it. So, like I said, we go over some of the patients that I would see here in the hospital. Malnourished patients, like I said, something pretty big that the dietitian's involved in. So in adults, we look at a variety of things. We can look at BMI, weight history, functional capability, amenorrhea, if someone's maybe lost their period, for example. We want to identify what the root cause is. So is it from disease, absorption issues, disordered eating, food access, other medical conditions, maybe they're depressed or something. And is the root cause, if it's that cachectic or that sarcopenic picture, because one of them we can help with nutrition and one of them there's not much we can do. So our intervention typically provide a high calorie, nutrient dense diet. There are specific oral nutrition supplements like Ensure and Boost products. They're all a bit different in their nutrient profile. And there are certain ones that are more appropriate for certain clinical conditions than others. If someone is malnourished, generally we will just take what they can get. If they don't like this Ensure, but they like the other, that's okay. We'll just take what we can get. A lot of these interventions rely on nursing and care staff for implementation, so mealtime assistance, encouraging or prompting oral intake. So although I might be making a recommendation for an intervention, nursing is really the bread and butter of our hospitals and of patient care. And then we can also offer other supports if needed, if appropriate. For our low socioeconomic status patients, these ones are, I would say, really quite sad to see. We can recognize barriers like food insecurity, limited resources. We can connect patients with community support as we're able to. Try and adhere to culturally appropriate and affordable diets. Unfortunately, there's limited options in the hospital for what we can provide. And then we can advocate for patients' nutritional health, like beyond hospitalization, but the reality is, if food security is the issue in the hospital, they're getting food. It's very often just resolved by being in the hospital. That solves a lot of their problems, and it's going home that the really big concerns arise. So nutrition in liver disease. I do see a lot of liver patients, and they could be anything from like someone with like decompensated liver, maybe not, depending on how extreme their state of the liver is. I might be more peripherally involved, or I might be quite heavily involved. Previous recommendations were actually for like to avoid protein for something like, hepatic encephalopathy. Now we know if someone's liver is totally just like out for lunch, not partaking in anything, high protein, high calorie diet, always protein regardless of hepatic encephalopathy. The nitrogen will not contribute to ammonia in the body, it'll be fine. We want to address malabsorption and nutrient deficiencies, so our liver is heavily involved in a lot of our fat digestion, so supplementing our fat-soluble vitamins is something to look at. So A, D, E, and K are our fat-soluble vitamins. And then if someone is presenting with edema or ascites, we want to limit sodium and potentially fluid to help manage their fluid status. The other thing I have on here is hypoglycemia risk with diabetes. So if someone has a compromised liver and they have diabetes, especially if they're on insulin or secretagogue, where they're at higher risk of hypoglycemia, we want them to have an evening snack, or at least not go a really long time without some sort of protein and complex carbohydrate food, because when our body is in a fasted state, a healthy liver will release sugar, glycogen, to maintain our blood sugar levels. But if someone's liver is compromised and they don't have access to that because they have a lot of liver scarring, then it's much more detrimental when they don't have access to that and their sugars go down and they're on insulin. Things can get really, really ugly really quickly. So disordered eating, I would think of this on a spectrum. So on one end you have someone who has a healthy relationship with food, and on the other, someone with a full-blown eating disorder. And then in the middle, you see people with dieting habits, strict habits around food and meals, spending a lot of time thinking about weight and body shape, things like that. So with our disordered eating folks, we want to identify signs of eating disorders or maladaptive eating behaviors, be very sensitive around this, and provide individualized nutrition care. So that might mean not having discussions about food or weight with patients because it can be really triggering. We would coordinate with psychiatry as we're able to, and nursing staff and whoever's involved, and then just support recovery and relapse prevention, and help safely discharge and arranging for follow-up. So there is eating disorder dietitians in Nanaimo who provide support to the Port Alberni area. They have a really lengthy outpatient referral form to fill out, but I'm always happy to do that when the patient wants that support and it's in their best interest. With enteral nutrition, so enteral is another term for just passing through the intestine. So oral feeding is technically enteral feeding, but that's just kind of a nuance. In the hospital here, we typically think of like enteral feeds as tube feeding. All of our enteral feeding options here are on the left. So these are all the different oral nutrition supplements that we have in hospital. So like our Boost and Ensure are very familiar to us. And then we have different isosource. There's supplemental like MCT oil, a fat, or Beneprotein, a protein powder that can be added. And then as we get lower down on the list, the products change from kind of like your standard formula to more hydrolyzed formulas, which is sort of like saying they're pre-digested. So they're easier to break down, easier to tolerate. So if someone had like absorption issues, something like that might be really appropriate for them. And then for a like fully hydrolyzed product with like free amino acids, if someone has severe allergies or severe malabsorption, that's when we look at those products. We never start with them because they're super expensive. When we're looking at someone for enteral nutrition, we want to make sure that the indications are there. So someone needs to have a functioning gut, or like if someone had a fistula in their duodenum, we can feed distal to it. We always want to feed the gut when we can, because it is it's the gold standard of care. It's the best option for our immune system. We're going to choose whatever formula is most appropriate for the patient, for their needs. So like we talked about, several different options. And then we're going to monitor their tolerance, their hydration, if they have any complications. Diarrhea definitely is like a well-known concern with enteral feeds. People often say, oh, like they're tube fed, of course they're going to have diarrhea. Studies have shown that 80% of diarrhea when on tube feeds is actually not related to the tube feeds. It's related to something else. So maybe the patient's on antibiotics, maybe the formula was left out too long and it's like a food safety issue, or that it was like contaminated, or maybe they were previously constipated, went on laxatives, and then everything's coming out. Diarrhea it should not be the standard for tube feeding. And then, based off of what we're seeing and how the patient's presenting, we will adjust tube feeds accordingly to optimize patient outcomes. Now, parenteral nutrition. So enteral is through the intestine, parenteral is outside of the intestine, so into our blood. There's two ways to administer it. So centrally through like a large vein. This is more long-term. Typically, we would see it through a PIC, but there are other ways. And then peripherally, called PPN, peripheral parenteral nutrition. This is for short-term use. It uses small veins, and these patients need to be good pokes because it is very prone to blowing. So if someone's not a good poke, I would not endorse this type of nutrition therapy. This is provided when our gastrointestinal tract is not functional, so it might be really malabsorptive. Someone has like Crohn's and a lot of inflammation. They might have an ileus, anything like that, or maybe they have a fistula really, really distal, and we need to be on like bowel rest. Formulating the parenteral nutrition, so we just want to make sure our macronutrients and our micronutrients are all distributed in such a way that our body will be happy, because if you give really heavy on something and not enough of the other, you'll see it in the labs and things will not look nice. This is our highest risk of nutrition support. So because you're delivering nutrition directly into the blood, you're skipping all of your body's natural buffers. So your electrolytes, your acid-base balance, like it is quite susceptible to change when doing this. So we exercise, I would say, a higher degree of caution with these patients compared to someone who's eating a regular diet. We want to prevent complications like infections, liver dysfunction. TPN-associated liver disease is no longer. We now refer to it as TPN-associated intestinal failure, or parenteral nutrition-associated cholestasis. So these terms have changed to reflect the multifactorial nature of liver complications when on parenteral nutrition. It's not the parenteral nutrition that's like solely causing these liver issues. They're actually, newer research is finding that it's the intestinal failure that seems to be one of the contributing factors to this. So diabetes management. When I do a diabetes assessment with someone here, I can assess like carb intake, blood sugar patterns, look at the diet that they're having. Our diabetes diet here operates under the assumption that someone is getting like multiple doses of insulin every day. So it's quite a carb-heavy diet because the goal is to prevent hypoglycemia always. So our diabetes diet is, well, I don't have control over what that looks like, but it is quite carb-heavy. So it's appropriate, I think, for the really frail people who are at high risk of low blood sugars. Most other people would be fine on our general diet here. I can provide education, so how to use a glucometer, an insulin pen, how to carb count. This is also something that can be done in outpatients, but if someone's discharged and they're new on insulin, then that is absolutely a safety concern that has to be addressed. I can go over like education, so self-management, lifestyle changes, and refer to our diabetes clinic for outpatient follow-up. Recently, we've started an inpatient diabetes management service. So this was inspired actually by Nanaimo Hospital. They have had a diabetes inpatient service for I think close to 6 years now. And it's been very, very successful in helping support patients in the hospital, physicians in the hospital, just take away from some of the hospitalist work, because diabetes often isn't the sole reason that people are here, but it does play a large role in like wound healing and how long patients are going to hang around for. So our diabetes team right now is myself, a pharmacist, and then either Sarah or Ian from internal med. Eligibility is if someone has high A1C, low blood sugars, they're on insulin, they have DKA, like all of that we can consult. Verbal referrals or like my referral form are just absolutely fantastic. We do rounds once a week on the patients, and then I kind of follow day to day what their sugars have been like in case something urgent comes up. Some doctors are really happy to have the diabetes management off their plates. Others prefer to be more involved in all aspects of patients' care. So we are being a little bit kind of selective and just trying to collaborate with physicians so that we're all on the same page about what's happening. Kidney disease. I don't see a lot of patients with kidney disease here, primarily because if someone's kidneys are really not good and they need dialysis, they're going to Nanaimo. So I often don't end up getting involved in the with kidney disease here. That being said, I definitely can and I have. What we look at is like protein intake, right? Our nitrogen waste. We look at electrolytes and fluid intake. And we adjust accordingly based off of labs, but that is something that in the bigger hospitals where they offer the dialysis, the dietitians are more involved there. So like I mentioned before, I cover the hospital and long-term care as well. So our long-term care center, there isn't funding for speech language pathology, which is really too bad because SLP is like, they have a really, really paramount role in our older populations and our long-term care. So I do the swallowing assessments there. Just like I do in the hospital, whether it's for swallowing or like a nutrition intervention, I do my assessments, make my diagnosis, recommend certain interventions. The difference in long-term care is a lot more of them are focused around comfort. So there's not the same like acute care interventions that you would see here. Most of the people I see in long-term care are either for dysphagia, weight loss, or wounds. And the other thing I get called for is resident preferences, just because they're there for a long time. So food fatigue is very real. And if someone said that they didn't like, I don't know, some sort of food once upon a time, muffins, let's say, or maybe they got sick off of muffins and it was removed, and then now they never get muffins again because that preference still lives in their chart. So sometimes just going through with a fine-tooth comb and making sure that people can have as much variety and that liberalized diet while they're in long-term care. Behind the scenes, so sometimes I hide in my office and I'm not on the floor. So I do a lot of like continuing education, different webinars and conferences just to stay up to date as part of my licensing. This year I did a 6-month course for diabetes education, and that resulted in our like quality improvement initiative, our diabetes rounds. I advocate for best care behind the scenes, so like I try to for nurses and patients. If I can make a nurse's life easier, I do try. This year we got the like new NG retention devices on the nose, so they're not the brown ones, they're like the clearish ones, and they're, I think, much better for tube feeds. I will attend education sessions before new products are used on the ward, so I can try and familiarize myself, and then, you know, if we have new pumps or new like NFIT, when that came to be, I can try and troubleshoot when there's issues. And then I connect with various reps from different areas to like sample products and kind of learn about them before I recommend them for patients. So that could be anything from like Ensure, Boost, One Touch, continuous glucose monitors, electrolyte replacements, things like that. So that I can, you know, potentially provide samples to patients if they're going home and need something to tie them over, and make recommendations for them moving forward so that they know what products are out there and what would be recommended for their best care. And then I will open it up to questions. I am, always happy to have questions, always happy to have someone reach out to me, phone, email. Thoughts?
Haley. For your referrals, does it have to be physician-led? Can nursing take the initiative? Can patient request it?
Yeah, so I have that referral form that you guys can fill out. It doesn't have to be a physician, it can be the nurse. I just ask that there's like a little bit of information provided, so like ticking whatever box, like if it's for GI stuff or diabetes, just so that I kind of know what I'm getting myself into. And a patient can absolutely request it. Just know that, you know, any of the referrals I get, they're going to be triaged. So if it's like diet preferences, and I have, you know, so I have a consult for diet preferences and someone else for they haven't eaten in 3 days, the latter is going to take priority. So, yeah.
I have a lot of patients that will request onsures and stuff. Like often some people aren't, hospital food's not their favorite, or that's what they do at home frequently, a lot of their elderly folks and stuff. Is that something that we can just add to their diet forms? Should we consult to you? Does it have to be ordered through you, or?
Yeah, so if someone normally takes it at home and they want it here, absolutely order it for them. I think it's great when we can have the hospital kind of mimic their home diet, because the transition then from hospital to home is a little bit more seamless that way. The one time where I would definitely want you consulting me is if like in your screening they've lost weight and they're not eating as much, and those concerns arise, definitely consult me. But if someone says, oh, I take Ensure once a day at home, can I have it here? Absolutely. Yeah.
Awesome.
Yeah. Anything else?
All good. Thank you very much, Chelsea, for doing this today.
Yeah.
That was a
Thanks for
great
having me.
presentation.
Cool.